So the next topic I'm going to touch on is to do with mental health. So I've already said a little bit about that this morning, but I want to focus in on one particular condition here, and that's anorexia nervosa. Yeah? So anorexia nervosa is diagnosed when a person becomes significantly underweight due to restricted eating, and it's, by definition, it reflects an intense fear of putting on weight and a distorted body image. So this has an onset typically in adolescence and early adulthood, affects many more females than males, and is often spoken about as the most sort of dangerous psychiatric condition there is. It has higher rates of mortality than any other mental health condition, and that largely reflects, well, I think it reflects a combination of things. One is an increased risk of suicide, and another is, of course, the starvation that's inherent to the condition can become very dangerous. So we're talking about a really serious problem here, but we're also, on the face of it, talking about a problem that looks nothing like autism, does it? I mean, it's to do with food. It's not to do inherently with the social world. It affects more females than males, unlike autism. And it has an onset in adolescence and early adulthood, not from the very beginning, which we believe autism to be, given that it's neurodevelopmental. Nevertheless, various people, including this guy, Professor Chris Gillberg in Sweden, in the 80s, and for all I know before the 80s, began to notice that certain clients that they had who were suffering from anorexia nervosa were women with an undiagnosed autism spectrum condition. And Gillberg wrote a sort of case series, sort of raising this as a possibility, which is essentially a series of sort of anecdotes of clinical cases that he'd come across, and then set about trying to systematically test this idea that amongst people experiencing anorexia nervosa were large numbers of undiagnosed autistic teenage girls and women. And they did this in a series of studies that took place in Gothenburg in Sweden, which have come to be known as the Gothenburg Studies, unsurprisingly. And for a review of the Gothenburg Studies, this Hugh et al. Paper is very useful. But fundamentally what they did was they had a cohort of 50 women 49 women and one man with adolescent onset anorexia nervosa. And they followed this cohort over a number of years, and that included conducting autism assessments with this group. And they actually did a number of different autism assessments at different points of time, and they're summarized in this table here. Now, I suppose the take-home message is that they ended up concluding that about a quarter of these women had autism, yeah, which is a really shocking figure. If you think in the general population, it would be 1/3%. Here they're saying a quarter of these women were autistic. Now, there was a certain amount of skepticism that greeted this finding, and I think rightly so. So for starters, if you look at these estimates, remember each of these estimates, prevalence rate of autism spectrum disorders, is in the same group of people, yeah, and yet they fluctuate wildly. So the first time they did it, they got 8%, and then 3 years later, they're suddenly estimating that 37% of them are autistic. And then it goes back down to 31, 18, 20, 18. So that's a bit worrying. That makes you think, well, maybe there's some error in their assessment, because the true prevalence of autism in this group shouldn't be fluctuating at all, but their estimates are. There was also skepticism because they used some slightly unusual methods for assessing autism and even some unusual diagnostic criteria that weren't ICD-10 or DSM-4, so that makes you worry a little bit about the validity of this diagnosis. But there was another reason that is perhaps more important as to why people were skeptical about this finding, that a quarter of women with anorexia are autistic, and that is starvation. Yeah? So inherently, people with anorexia who are acutely ill with anorexia are experiencing starvation. And what we know is that starvation has an impact upon our psychology. And part of that impact is to create behaviors, motivations that could be mistaken for autistic symptoms. So this is a famous study called the Minnesota Starvation Experiment. in which some people at the end of World War II in Minnesota agreed to be starved so that the US government could learn more about how to re-nourish people who were starved, because they knew that World War II was coming to an end and there was going to be lots of starved people all over Europe and Asia who would need help. So these guys, they signed up. They dropped 25% of their body weight while guys in white coats stood around kind of watching them and monitoring them, and then they were re-nourished. And what they noticed was that these men became less socially motivated, less flexible, and they developed quite fixated interests, funnily enough, quite often on food and cooking. So the accusation is against the kind of Gilberg findings is that you've taken a bunch of people who are starved and highly anxious and perfectionistic, and you've misinterpreted their symptoms of the starvation, the anxiety, the perfectionism as symptoms of autism. And that seems to me a pretty reasonable sort of objection to raise to this finding that a quarter of people with anorexia are autistic. However, there have subsequently been done a bunch of studies that continue to support the original Gilberg finding, despite being of a higher methodological quality. So, for example, some work that I did with Heather Westwood and Kate Chanchuria at the Maudsley, we used a more rigorous autism assessment based on parent reports and also the ADOS in a group of adolescents and adults, women who were receiving treatment for anorexia nervosa at the Maudsley. And again, we came back with this figure of around 25% appeared to meet criteria for autism. This group in Italy used the RADS, a self-report autism measure with fairly good support for its validity. And crucially, they used those questions of the RADS that ask about historic symptoms. So they asked people to report on their potential autistic symptoms from before the onset of their eating disorder. And they continued to find high rates of these autistic symptoms reported, again, in the order of 25 to 30% of people having autism. And also, from the Gothenburg Studies, Ankersater et al. Published a more rigorous, a better conducted autism assessment in that Gothenburg cohort after they'd almost all recovered their body weight, and they continued to find 25 to 30% meeting criteria for autism. So, you know, it's quite hard to argue off the back of this that this is just an illusion. It seems to me the evidence points much more clearly to this idea, and certainly this is backed up by my conversations with eating disorder clinicians and by the assessments I've done in women with eating disorders, that there is a substantial proportion of women who are presenting primarily with severely restrictive eating who have an undiagnosed autism spectrum disorder, and that may be as high as 20 to 30% of those who are receiving treatment for anorexia nervosa. Now, this matters. Women with anorexia nervosa in the context of autism, usually their autism is unrecognized. They seem to experience the worst outcomes amongst AM patients. Yeah? And given that this is a condition that doesn't have particularly good outcomes in the first place, that's not great. There's also emerging evidence that those with high autistic traits presenting to eating disorder services benefit the least from current eating disorder services, from the treatments and the support that is on offer in eating disorder services. And in the UK, we have NICE guidelines. I don't know if people have heard of these. So these are like the government essentially pays for bodies of experts to summarize the available evidence for a particular condition and to sort of spell out for clinicians what an ideal treatment plan would look like for that condition. And there are NICE guidelines for anorexia nervosa. So they're meant to be a synthesis of the latest evidence and to guide service development and treatment for anorexia nervosa. And they were done just last year. And what I find extraordinary is that the word autism does not appear once in those guidelines. So my sense is that eating disorder services have a long way to go, and yet in terms of recognition, and yet maybe as many as a fifth to a quarter of their patients, unbeknownst to them, are experiencing autism. So we've recently started a project to try and improve the situation with the hope of trying to kind of contribute to knowledge to improve the situation. And we've got two main aims. We want to work out how can eating disorder services become more autism friendly. And we've also got this idea that maybe the restrictive eating problems that we see in autistic people may not actually be the same thing as anorexia nervosa that we see in non-autistic people. They may actually have distinct causes and mechanisms and perpetuating factors, and I'm going to come back and talk about that in a moment. So we're also interested in getting a better theoretical understanding of adult restrictive eating problems of autistic people that could inform interventions. So we're going to do some qualitative work to kind of map out the terrain there, as you can see I've done in other areas, and then we're going to test out those hypotheses quantitatively. But I just wanted to share with you, again, this is essentially a kind of just slightly above the sort of status of anecdote, but nevertheless the early findings from our focus group work and our conversations with autistic women with eating disorders and expert clinicians on some of the potential ways, directions this research is heading. So, for example, practical ways in which eating disorders services can become more autism friendly. Awareness of sensory issues is a really obvious one. So I remember talking to one person who had, part of her treatment was that she had to go 3 times a day into a certain room that was in the clinic, and she had to finish her meal, so that she could retain her body weight. Now that room was noisy, and it was lit with fluorescent strip lighting, and so she had not a chance of fulfilling this very difficult task of eating that food because she was dealing with this sensory overload, and there was no awareness of that in the service. So simple steps like people being acknowledged, sensory issues being acknowledged. Another interesting one is that a lot of this work is taking place in adult services. And I've had quite a few conversations with autistic women who said, actually, they didn't really want my parents to be involved. It wasn't in their model, it's not what they expected, and yet my parents are a very important part of my support network, and I would find it helpful if they could come to appointments, they could help me retain information, they could be involved in my care in a model that you would expect to see more in a child and adolescent mental health service. Group work. There's other instances where in some of these centres, the idea is you sit round in a group, reflect on your feelings, so on and so on. That can be a real barrier for some autistic women. And again, it becomes a situation where the treatment is adding to your problems rather than subtracting from them. And a general theme that is emerging from our data is greater autism awareness. Now, what about this idea of developing a better understanding of what causes and maintains restrictive eating difficulties of autistic people? Because what we're working from here is a broad overarching hypothesis that in many cases, when an autistic person is diagnosed with anorexia nervosa, that's actually a bit of a mislabeling of the causes of their restrictive eating. Because remember, anorexia nervosa really is inherently related to weight and shape concerns, to worries about being fat, for a desire to have a different body shape. And yet many autistic people that we've spoken to who've been diagnosed with anorexia nervosa report having had very, very little interest in their weight and shape, and that actually their restrictive eating disorder, which was reducing their weight, was driven more by characteristics of their autism. So, for example, I remember talking with one person who found that she reflected that she'd had several episodes where she'd been hospitalized due to very, very low body weight. And these had always come at times of great uncertainty in her life, transitions between roles, times when she felt out of control and uncertain. And at those moments, she'd fallen back on the mathematical certainties and comfort of counting calories and of running certain amounts of miles a day that had felt just really right to her. And as a result, she controlled her anxiety, but she also, as a side effect, lost weight. And she said the weight loss terrified her. She had no interest in the weight loss. This was a kind of autistic strategy to manage a situation that in some senses felt unmanageable. Another important idea emerging from the data, and again, I'll report back to you in a year or two's time about whether this is actually confirmed properly, through proper scientific investigation. But the notion of starvation as a way to shut down anxiety, but also sometimes to shut down sensory difficulties I found that very interesting. I've had several people say that to me now, that actually in a starved state, some of the sensory overload becomes less problematic, as does anxiety. So again, you begin to understand, in some cases at least, the restrictive eating that gets labelled as anorexia nervosa as perhaps something a little bit different. Now, of course, the problem there is that if you're in that position, let's say you're an autistic person who has got a BMI of 14 or something, and you're being treated for an eating disorder, quite often you're just going to be given a one-size-fits-all anorexia treatment, perhaps CBT to treat your weight and shape concerns. Now, what about if you don't have weight and shape concerns? You can tell the psychologist that. They may not even believe you, because apparently lots of people in eating disorder services say they don't have weight and shape concerns. And so there's a risk, again, that people are being given inappropriate treatments, and even treatments that might be doing more harm than good. And there's this interesting possibility, that actually, are restrictive eating problems in autistic women really anorexia nervosa, or are they sometimes ARFID, avoidant restricted food intake disorder, which is this category that popped up in DSM-5 that had previously been one that was applied to children but now is applied across the lifespan, which is a term for severe restrictive eating, but which isn't driven by weight and shape concerns, but which can be driven by things like sensory difficulties and a range of other factors as well. And I think this case of eating disorder, this notion that there are people presenting to mental health services who may have an undiagnosed autistic spectrum disorder, which could actually be feeding into their mental health difficulties, goes well beyond eating disorders, I would say. So, for example, we've done work in a specialist OCD service. So this was a service just north of London, which is like a national service. So it's fundamentally, it's kind of for people who haven't responded to OCD treatment in their local services. They can get referred on to this more specialist service. And we found that a large proportion of those individuals, including of the women who were presenting there, had, according to our assessment, which was a pretty good assessment that was involved a proper clinical interview, had an undiagnosed autism spectrum disorder. And again, an interesting line of inquiry will be to the extent to which, was the OCD that those people had, a kind of, in quotes, classic case of OCD, as would be formulated by cognitive behavioral therapy, a kind of safety behaviors, trying to manage responsibility beliefs, or actually was it more a kind of more neurodevelopmentally driven condition that would require different types of treatments and different ways or different types of management.